Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you. Thank you for the introduction. I have 100 slides and I'm going to make every one of you listen to all of them. Yeah, I'm kidding. I've got 90. Don't worry. No, thank you very much for staying. We call this the graveyard shift, but I see you have the passion to stay back, and really thank you for being here at this time. So I'm going to try and be as quick as possible, make it as painless as possible for all of you. So nothing to declare, no conflicts of interest. As you can see the agenda, I'm just going to talk a little bit about the burden of the disease, getting the diagnosis right, because it has some serious implications, investigations, overuse or over-reliance of SABA. So this is a big issue, not just in the UAE, but I guess a lot all over the world. The SABA inhaler is very famous, very popular, very easily available over the counter, but it leads to a lot of issues. So we need to discuss that. And then some practical tips. So I'm not sure if you're aware of the GINA organization, but they have given out guidelines which are kind of practical, evidence-based, and they are not influenced by any other pharmaceutical company usually. And some take-home messages. Things that I cannot cover in 20 minutes obviously are asthma in children, pregnancy, occupational asthma, and very severe asthma, which accounts for only about 4% of all the asthmatics, and also management of exacerbations. I'm afraid I don't think we'll have time for all of that. So the overall burden, the global burden, as you can see, I guess by 2050, we're saying we'll probably reach about 400 million people with asthma. And the thing that troubles the patients most is an experience of having an exacerbation. It has health cost implications. It has, as you can see from the statement at the bottom, patients really feel that they're about to die, which probably, I've never had that feeling, but I can imagine it may not be pleasant. This is the local burden from Gulf countries, and you can see the prevalence ranges from about 10% here in UAE to about 42%. We don't know exactly what the cause could be, but we've been told it could be the excess amount of the extensive construction work that goes on, or the dust storms that you get, plus all other triggers that you may have. The epidemiological data does suggest that there is a lot of money being spent on asthma management, and it varies from country to country. As you can see in UAE, we are in the 23 and 28 million mark, but if you go to Kuwait, there's 208 million with half the population. So a lot of money is being spent. Now, we don't know why that is, whether it's related to not enough education and awareness about the condition, or not enough awareness and education about the medications. But I think a lot of work is being done. I'm just going to briefly mention some terminology, some terms that we use in asthma, so that, for the further, as I go through my presentation, it may become a bit easier. Poorly controlled asthma. This is a term we use when we say that the diagnosis is right, but for either patient reasons or doctor reasons, the asthma is not well controlled. Mild asthma is a slightly misnomer, but if it gives the impression that it's okay, it's mild, don't worry about it. But evidence suggests that even mild asthmatics are likely to have quite severe exacerbations, depending on whether they get the right trigger or not. So it's not always mild to say that it's, we have to be careful when you use that. Severe asthma is uncontrolled despite using maximum therapy. And I'll show you what I mean by step 5 when we come to the GINA guidance. Phenotypes, we try and differentiate patients and put them in different categories based on the clusters of characteristics that we find, so that we can taper our therapy according to them. Type 2 inflammation, this also comes later on when we're not able to control the asthma. Then we look into inflammation, which we can target with newer biologic drugs. A newer term comparatively is the anti-inflammatory reliever, but it's the name given to an inhaler, but that usually has an inhaled corticosteroid. And I'll show you some examples of that later. MARD therapy, not probably relevant to this talk, because I'm going to talk most about the milder form of asthma that accounts for about 70% of all asthmatic patients. But MARD therapy, which is used, is maintenance and reliever therapy. So, and we'll talk about it a little bit later. It's important to get the definition of the exacerbation right as well, because some measurement that we make about whether you've had an exacerbation or not actually depends on how you define exacerbation. So exacerbation can be moderate, it can be severe, but it means progressive increase in symptoms requiring a change in the treatment. That's a very simple definition given by the GINA. So I always say to make a definition, to make a diagnosis of asthma, I think it's very important, like us all being physicians, go back to the basics, take a good history, and there's no replacement for that. There are some certain points in the history that I'll mention in the next slide. But once you've had a good history, then I think you follow that with the investigations, which I'll talk about. But that is to demonstrate evidence of variable airflow limitation. And then it's important also to document the basis of an asthma diagnosis. This is also essential. This is also recommended. You should say whether you have any subjective evidence or objective evidence and whether the patient is being reviewed after you've made that diagnosis. You can't just make the diagnosis and abandon the patient. So asthma is a chronic condition. Again, very important to know that it's a chronic condition. You may have acute episodes, but it's definitely chronic inflammation that goes on. And it causes recurring flare-ups and symptoms. And as you can see, the bronchioles that have been demonstrated here, the more frequent exacerbations you have, the more likely that there will be remodeling of the epithelium in the bronchi, and they will behave more like a fixed airway obstruction. GINA, as I mentioned earlier, the Global Initiative in Asthma Management, have defined it in a very nice way. I like the definition because it tells you about the pathophysiology, the clinical aspect, the signs, symptoms, the triggers, and it also tells us what to measure and what tests to do. So I feel this is a good definition if you want one. Coming back to the basics about the history. So if you see the left side of this, the column, you'll find that the characteristics mentioned on the left side in your history are likely to make a diagnosis of asthma more likely. So we are saying more than one of these symptoms, nocturnal or early morning. Symptoms vary over time, so variable or episodic, and symptoms which are triggered. A very good marker is also asthma that was present during the childhood. So you'll be surprised to know that if a diagnosis of asthma has been made in an adult, in 50% of the cases, if you go back to the history, you're going to find that they had asthma as a child. Whether they had features or a definite formal diagnosis or not, that depends on how you take the history from them. And also some associated atopy-like features. On the other hand, asthma is less likely if patients come and say, I've got tingling, I've got a headache, I've got chest pain, I've got very noisy breathing, production of sputum. So those things take you away from the diagnosis of asthma. It may be a lot of other things that I'm going to list. So just if there are any residents left in the audience, just a recap quick about not all wheeze means asthma. So you need to think about other things. Inducible laryngeal obstruction is very rare, but it is something that needs to be demonstrated during an acute episode when the vocal cords tend to, and I'm not sure how the patients manage to do this, but the vocal cords tend to oppose, and it creates a clinical picture of what looks like an asthma exacerbation, but it isn't. So it has to be investigated with a laryngoscopy by an ENT surgeon when it actually happens. But other differentials, as you can see there for wheeze, other differentials for cough. If you have a chronic cough in a patient with a normal X-ray and normal lung function test, you need to think about these all a list of other things. And also breathlessness. There are other differentials. So why is it important to get the diagnosis right? For a couple of reasons, a couple of very important reasons. One, maybe you're missing some other vital diagnosis, which you don't want to miss, which is rare, but this issue remains a lot. So in this particular paper back in 2017, they found that about a third of the diagnosis of asthma that they had made, when they went back to those patients, they couldn't find any features of asthma, and they had to slowly wean them off the medications over a period of 1 year with close monitoring. So if you don't make a diagnosis properly and don't document it, don't have the evidence, then you are unnecessarily probably treating a third of your patients. This is again a huge issue. So there is more and more information that evidence that's coming up that if you use even 3 or 4 courses of short burst oral corticosteroid courses in the adult life can lead to later issues in life in terms of diabetes, in terms of infections severe enough for some patients to actually end up on ICU. So there's a big burden. So I think for a couple of reasons, very, very important that we don't misdiagnose or make it wrong. So are we aware of any investigation that will give you 100% yes or no? Unfortunately, no. It has to be put in context. So there is a range of things in primary care. Peak expiratory flow rate and a chart over a week is helpful, but the variability between peak flow brands from one peak flow to another is about 20%. The number that you'd normally use to put a cutoff and make a diagnosis, that's the kind of variability. So it has to be the same peak flow, you have to train the patient how to use it and document it. And then you have to look at the chart yourself and come to the conclusion whether there is a significant 20% of above variability in the peak flow readings in the morning and the evening. But it's a very basic, easily done, but there are some caveats to it. Very helpful, and the FEV1 is much more reliable, much more accurate than a peak expiratory flow. So wherever you've done your history, you've done that job with your communication with the patient, then I think a spirometry is the next best thing. And then you don't necessarily have to have an abnormal spirometry, but you may find that if you repeat the spirometry so often and the patient does have asthma, you are likely to find a spirometry 6 months ago or a year ago with numbers which are higher, and a spirometry now its numbers are lower, or vice versa. But basically, we're looking at a difference of FEV1 of more than 12% or 200 mils, a difference FEV1. That tells us there is a reversibility. That tells us there is some inflammation going on that goes with the diagnosis of asthma. Some other tests that I've mentioned here are more relevant to severe asthma. This is again something very close to my heart because at Zayed Military, I don't know if you're aware, but for all local Emirati citizens, they have to go to the national service. So once they've been diagnosed as a child, or anybody else trying to join the army, if they're diagnosed with asthma outside without a definite evidence and they come to us, it becomes our job to actually confirm that diagnosis or refute it. But once you've made the diagnosis and told the patients they have it, it's very difficult to get that out of their mind to say that you don't have this condition. So it was mentioned back in 2014 that the cause of death in asthma could be related to higher reliability and over-reliance on SABA, which is Ventolin. And we've got evidence from 30 years. It's not new. We've got evidence that the more SABA you use, the more chance that this is demonstrating human behavior, that this was a telephone survey where patients said when they had an exacerbation or a feeling that the asthma is not controlled, the thing they'll reach out to first will be a Ventolin inhaler rather than an inhaled corticosteroid. More evidence, but present from a long time ago, that using more SABA causes more symptoms, lower lung function, more airway hyperresponsiveness, more exacerbations. It leads to more hospital admissions or ED visits, and they end up receiving oral corticosteroids. So just purely using salbutamol or a SABA without an inhaled corticosteroid is harmful. This is the message I'm trying to get through. There's also an environmental implication on it. And on this paper, you can see that the use of SABA has got a much higher carbon footprint than other controller inhalers. Is there an alternative? Yes. So there is two very big and important studies done, Sigma 1 and Sigma 2, which has demonstrated that the use of a combined inhaler, ICS, LABA, inhaled corticosteroid, and long-acting beta agonist is much better compared to just SABA on its own or just an inhaled corticosteroid on its own. So it reduces, it shows that you have better control of your asthma during the week. It has reduced exacerbations, and it has reduced the dose of the steroid needed to control. So if you use just an ICS inhaler, you're likely to need more of it compared to a combination ICS and LABA inhaler. So these two studies, this one was more controlled and patients had reminders and there was an electronic diary that they had to maintain. But this one was more pragmatic, follow on from the Sigma 1. And it also demonstrated that a combination inhaler, ICS LABA, is much more helpful than just ICS on its own or an ICS or a SABA combination. So again, more evidence. I'll keep moving on. So, but the thing that the patients mentioned to us is the blue inhaler is magic. I cannot give it up. So what is the solution? Evidence shows, and this is a very good study, they've compared 100 micrograms of salbutamol, 200 micrograms of salbutamol with formoterol. Formoterol is a long-acting beta agonist, so 4.5 and 9 micrograms. And you can see the onset of relief can be similar, about 3 minutes, and it's sustained. It's sustained over a period of time when you compare it with salbutamol. And sorry, at different doses, 100 and 200 micrograms. So there's nothing to say that this combination inhaler, ICS and LABA, is not as good as a Ventolin. It's just how you convey it to your patients and tell them what needs to be done. So based on all that information, this is sort of practical advice that can be used in your clinic based on the GINA guidance. We like algorithms, we like sort of flowcharts, but this shows the track 1 shows that we can use the ICS for formoterol. Step 1 and step 2 are for mild asthma, 3 and 4 for moderate, and 5 for severe. But track 1 is the preferred track where you can use just one inhaler, just one ICS LABA combination. And patients prefer that. That's behavior. Patients want just one inhaler. In track 2, it does say you can use an ICS inhaler, but every time you use an ICS, you should also, every time you use, in track 1, it says ICS only when required. But later on, if you need more of the ICS, then you can use a higher dose, but patients need to carry 2 inhalers. You can have a regular ICS inhaler, but you also need to carry a Ventolin, which is behavior-wise from our clinic, I find it's extremely difficult for patients to adhere to this sort of advice. One inhaler is probably going to be what they're looking at. Again, very important. So most of the asthma clinics, we do have asthma nurses, we have pharmacists, we have psychologists because of the way patients behave with their asthma. But it's communication, it's revision, it's assessment, it's how the patients behave and whether they adhere to the medication or not. Subjectively, yes, we can get the information, but some numbers we need come from the asthma control test. This is something that we give to the patients when they come and sit in the waiting area. They fill in the form, and then the number gives us an idea whether it's controlled or not. Based on that, you can move up and down the track, step 1, 2, 3, and then reassess after 2 or 3 months to see if the control is better or not. This is just the example of all the inhalers that are available in the market. The one at the bottom, Flutiform, is a combination, ICS LABA, but it's not licensed. The one in the middle, those 2 in the middle, Symbicort and the Durest, are actually licensed for use for the track of treatment that I showed you for GINA. Asthma action plan, again, something else to be given to patients. Again, down to your communication, how you make them aware. Health literacy is a very big thing. And I think compared to, I'm sure, all of the conditions that you deal with, hypertension, diabetes, health literacy is a very, very big issue. So you have to sit down and explain to patients about the consequences of not using the treatment. But also, when they have an exacerbation, it leaves a mental scar. So to prevent that from happening again, you can have a good discussion with the patients, explain to them, give them an action plan, rather than just say, when you have an exacerbation or some symptoms, why don't you just use a blue one or go to the emergency? You can give them the control. You can give them something objective to look at. And this action plan was actually from New Zealand that I downloaded, but there are some available on Department of Health website. There's one also available in Arabic that I found on the UK website. So I'm going to stop there. So just a quick summary. You need to try and get the diagnosis right at the beginning, because as I mentioned, once you label somebody for various reasons, for psychological reasons, if you want to take away those inhalers from the patients and tell them you don't have asthma, they're not going to listen to you. Overuse, over-reliance of SABA, and I've showed you, demonstrate you very quickly some evidence about why it's not safe to just use it on its own. And there is an alternative. There is the ICS LABA and health literacy, education, discussion, action plans. When in doubt, obviously, when you're approaching towards the 3, 4, and the 5 steps, then obviously these patients will be heading towards a specialist clinic. And like all pulmonologists, I can't finish a talk without, stop smoking. Very, very common amongst the youngsters. Very, very common. Vaping, midwar, very, very common. So need to focus on that as well. Thank you.